So our next to last speaker, I'd like to introduce Dr. Jeff Catrambone, and he's the Director of Pediatric Neurotrauma at the University of Medicine and Dentistry in Newark, New Jersey. He has a couple of PowerPoint slides to show. So he's going to show them. You have to find them first. There we go.
Okay.
Dr. Catrambone.
Thank you. This is the following patient, KH, a 9-year-old with a 2-week history of nausea and vomiting. And she presented to a private endocrinologist with 2-week history of the nausea and vomiting. She also had excessive urination and thirst. She was sent to our affiliate hospital, JCMC, for evaluation. And after her imaging studies, was sent over to our hospital. She had a history of a high cholesterol for 2 years, controlled by diet, and she also was noted to be small for age. And on admission, she was urinating approximately once per hour and drinking almost 3 liters of fluid per day. So her physical exam demonstrated that she was small for her age. She was awake, alert, and oriented person in place. She had no nuclear rigidity. Perla with extraocular motor muscles intact, no visual field defect. She did demonstrate a right upper and lower facial palsy. She was profoundly deaf in her right ear with no nystagmus. And she did demonstrate gross hyperreflexia in bilateral upper and lower extremities. This was her initial CT scan that was done at JCMC. And this is what ended up warranting her transfer to our institution. This is some of her preoperative MRI studies demonstrating a large lesion within the infratentorial space and also a cellular lesion with a lesion in her third ventricle. She also demonstrated some moderate hydrocephalus. The axial FLIR study shows some transependymal flow. And this T2 study also demonstrates a stretching of her cranial nerves with a gross shift of her brainstem. So the question is what to do and how to treat this. We could go to the Dextroscope now. So my thought process in this case here is that I wasn't sure what I was dealing with. I suspected that this was probably a cranio based on the calcifications in the sella, but I also suspected that could have been a dermoid or epidermoid. And what I was thinking while treating her is a couple things. One question I had was, could I take this out? Could I take this out successfully, safely, completely? And my answer was probably not. So what were her problems, and how could I alleviate her symptoms and control her problems? Her problems were hydrocephalus, mass effect in the posterior fossa, potential for upward herniation if EVD was placed supratentorially. And so my plan for her was to take her to the OR and to do a posterior fossa procedure first, find out what I was dealing with and how successful I could be to take it out, and then approach her supratentorially at the same sitting. And my plan there was to do an endoscopic approach and to fenestrate her septum pellucidum and a third ventriculostomy and see if I could alleviate her hydrocephalus. What I found interesting was on using the Dextroscope and doing some preoperative planning for the posterior fossa, it became clear to me that this could be approached through a suboccip and not a retrosig, and that would bring me to the tumor quite quickly. The other thing that the Dextroscope was helpful in demonstrating was the relevant vascular anatomy and its relation to the tumor. It was clear that pica was involved in this tumor. It was from the films, it suspected that this was actually attached to the brainstem in addition to shifting it, and would be attached to the cranial nerves. So we approached this from a infratentorial approach using a suboccipital craniectomy. The reason to do a craniectomy was I thought that without taking this tumor completely out, that it would definitely reoccur, and that if we did a craniectomy and particularly did not close the door and left everything open, that her bone would not grow back, and that having an open container as opposed to a closed skull would give her more time in terms of recurrence of symptomatology. So using intraoperative MRI guidance and an endoscope, we took her to the OR with these images, and we did our infratentorial approach. Then, after we completed that and drained as much of the cyst out and took as much as we safely could, we did a supratentorial approach using 2 burr holes, and one of them was a more laterally placed burr hole, and we fenestrated the septum pellucidum to make sure that the 2 ventricles were communicating. Then we went in through the foramen of Monroe, and we went after the tumor, drained it, and took out what we could safely through that approach. Using the intraop MR, the Odin system, we demonstrated that in that setting, there was no communication in the 3rd ventricle to the 4th at all. But we did perform a 3rd ventriculostomy, and we performed a MRI the next day to see where the CSF flow pattern was, and I can show you those films. The other thing that I think is very helpful, and in fact I'm going to be presenting some information at the CARS meeting June 28th to July 1st in Osaka, is the use of this device for pre-operative planning for the 3rd ventriculostomies. I think you get a great appreciation where the basilar artery is in relation to the floor of the 3rd ventricle, and at least for me, it brings me a lot more confidence when I'm doing the procedure or where I think all the anatomy is. And in cases where the floor of the 3rd ventricle is not as thin as you would like, going in there with a more careful understanding of the anatomy, you can safely put your hole without worrying about perforating the basilar artery. So what I would like to do is then go back to the slide show here and then just demonstrate something that I think is very interesting. And here's the actual FLIR demonstrating some transependymal flow. This is a CTA, which shows calcifications in the sella. So as stated, we did a 2-part operation all in one sitting. This is the intraoperative photo showing using the Odin system, the head holder. And these are some intraoperative pictures. On the left upper corner is our actual craniectomy. And on the right shows the intraoperative film, what we use for navigation. What's nice about this is we can take our endoscope and we can track it in real time, and I can put it wherever I want and know exactly where I'm at, which I find quite helpful not only for cases like this, but also for cases of complex hydrocephalus and fenestration of cyst. This demonstrates some of the cyst contents that were aspirated. And her postoperative course, she remained intubated overnight. She did have some DI that continued. However, by AM of her postoperative day 1, her dysfunction of 7 and 8 virtually resolved. Her long track signs improved. And this image here I think is very interesting. This is, unlike her intraoperative MR film, this demonstrates that with the 3rd ventriculostomy, the GAD is now communicating everywhere. This is a T1 study. And she has remained shunt independent. And other than her DI, which is now being controlled with medicines, she's virtually intact and has remained since her operative experience. As you can see from this post-op film 2, her 4th ventricle is now open. Her midline shift of the brainstem, although still present, is much improved. And this is a further study. So the pathology, as explained, was craniopharyngioma. She did have marked gliosis with Rosenthal fibers and some xanthoma cells with cluster clefts. Thank you for your attention.
Thank you very much.
Sure.
Any questions for Dr. Catrambone while we load our last presentation? No?